Hello, guys, and welcome back to my pre recorded webinar session at the Diabetic Desk. My name is Charity Wanyonyi. I'm the founder of the Diabetic Desk, a platform where I talk about everything diabetes, nutrition, and in between. So, thank you so much. Let me set my camera well so we can see each other. I'm so excited. So, today, I'm going to talk about a little bit of a controversial topic, as you can read on the screen. What nutritionists wish doctors knew about diabetes management, and not necessarily doctors, also even healthcare professionals who are interacting with diabetic patients. So I'm not here to compete. I'm not here to bash or talk bad about any health professional. This session is just to encourage collaboration between healthcare professionals. So please stay tuned. And for me, this is experience because I've ever worked in a diabetic clinic for a while. And that is where my passion for diabetes came. And I got to interact with people living with diabetes. And what I have learned is while medicine stabilizes blood sugar, nutrition, behavior, empathy that truly sustain the control. Also, I think as I'm writing my paper and I will soon be defending my work and publishing it, I've gotten to know the knowledge, attitude, and practices really intertwine. So you cannot just do the technical part and leave the empathy part because people feel like they want to be heard and they're going to look more as the session continues. So I feel like today is not just about what is missing. I feel like it's what collaboration can benefit us as healthcare professionals and people living with diabetes. So, why does this conversation matter? When we look at the current global picture, we see over 589 million adults are currently living with diabetes, and this number is expected to have an increase to about 853 million people by 2050, which is quite a lot. And the way we are living, I feel like the number will even be more. I feel like I will start with this quote. Diabetes management is not just a clinical thing, it's a behavioral and nutritional thing too. It's not just the number, it's a reminder that diabetes is growing faster than our system can adapt. And what is striking about all this is that 70 to 80% of diabetes outcomes are mostly influenced by what the patient eats, how active they are, and how well they understand their own care, not just medication, and that is according to WHO. And yet, in most settings, nutrition is, I feel like these days is prioritized. I'm not going to talk bad about, because there are people who have truly integrated nutrition into the system, but there are places where nutrition is not prioritized as part of the standard medical review. And I appreciate hospitals that have really incorporated nutrition as part of the plan. When the patient is newly diagnosed, they go through everything so that they are well equipped. And I feel like that is why this conversation is important and it matters, because diabetes management is purely medical. It's deeply behavioral and also nutritional. I feel like we've seen, if you've ever worked with a diabetic patient, you're working as a team from the doctor to the nurse to the nutritionist or dietitian to the pharmacist to the mental health practitioner if they're on board, community health promoters who go back home to make sure everything is okay. So I feel like this conversation is very, very important because when nutrition is integrated into the plan, glycemic control, medication adherence, and quality of life is improved. I want to look at where the gap begins. The system is strong medically, but I feel like this is according to me. You can leave them in the comments of this video, but nutritionally weak. Yeah, because I've interacted with many medical practitioners throughout my experience, from attachment to internship to my years I was working in the hospital, and doctors will tell me, just you see, nutrition, we just did it like a sub or a core unit, like the way we did leadership, a core unit. So we really not versatile about what it is. And as we've gone to school for 4 years to study what nutrition is. So you'll find that doctors are the first people who interact with patients, and their work is to diagnose, to prescribe, and make sure the medical aspect is taken care of. So you find that even if they notice something wrong in the nutrition sector, they will not have time to now start talking about the diet. You cannot prescribe, you cannot diagnose, and you still go and cancel. So I feel like they still have limit. If you're a doctor and you're watching, you can leave in the comments. They still have a limited time when it comes to consultation, because if you have almost 20 patients to see, you'll not start prescribing that to them. And patients sometimes, cause maybe kama ameenda clinic na amepata watu wengi, the patient will just live with the medication, but they will not go through, because each clinic visit, you're mandated, let me say that, to visit a nutritionist to make sure you're up to date with what you're supposed to eat, to see the medications you're given, to see, and just continue educating, because mtu anaweza ambiwa leo ukitoka umesahau. So if you don't understand how to eat for blood sugar control, especially for the newly diagnosed one, you're going to have a hard time, because the medication will not help when you're taking the medication and you're still eating what you're not supposed to eat, or you're just eating beyond the portions and spiking your blood glucose level. So generic handouts often say avoid, that is the language we are running away from. Avoid, reduce, do this, eliminate this. I feel like it comes, and this is from my own personal experience, it comes so hard, because they're telling you, mimi siwezi acha sukari, nitakunywa nini? And so this you're telling them, but translating it into the real life is quite difficult, their eating pattern. That's why you might find a patient, we're going to look at a case study later on, who is on medication, but their sugars are constantly high. So this gap leaves space for misinformation from social media experts to really push their diets and trends and procedures on people. And I feel like this is where us as nutritionists come in, to translate the clinical goals into making them a reality. So you can see if the doctor, we're going to look at the challenges that come with this, sees maybe it's the diet that has a problem, and just right for the patient to see a nutritionist, and make sure the patient, akitoka hapo, the patient has gone to see a nutritionist, so that you can avoid or fill that gap, so that they don't get that information from somewhere else. We're going to look at what nutritionists see every day. Most of the time, I remember when I encountered my first patient, was just diagnosed that day, because he came in with sugars of 30, and he was having a really hard time, because he was saying ati wanamwekelea and he feels fine. Uh, they took the readings almost 5 times, they were still high. He went home, he came back the next day, they took the fasting, because that was random, the fasting was still high. So he was told, you have diabetes, and he was very agitated, he was very confused, and he was like, I'm going to beat this, I'm going to. So the first month was really hard, because the patient did not adhere to anything, wasn't taking medication, was just eating anyhow. So he came back when the sugars were really, really critical. So every day you come across some feeling anxious about living with diabetes, some confused, some feel guilty because they've been told this is what you're supposed to eat, and they go and eat this. So some of them say, sasa anaenda kuacha kukula how I eat and all that. So you'll find that we come across cultural staples. These are day-to-day foods that we as Africans we eat: ugali rice, and without proper education and know which type of carbohydrates you're supposed to eat, it's going to really give the patient a hard time, because when you view food as bad, you're already establishing a negative relationship with that food. And this is our day-to-day staple. This is a food that a common mwananchi can afford. Unajua ukifanya assessment, I wrote on my compass on Wednesday, I wrote about nutrition assessment as our compass. And you'll find if that is what they can afford, the economic realities of the patient is, I cannot afford the food you're telling me. I can only afford the food for a common mwananchi. So you have to really sit down and come up with a meal plan or a plan or an intervention that will work for this common mwananchi. So eating, emotional eating because of stress, and people living with these lifelong diseases or conditions usually experience some form of mental health destabilization. There's work schedule, there's family pressure. I feel like maybe the man is not the one who is cooking them. And when they come to the clinic, you're telling them come together, but to find the man is coming, you're counseling and advising, but doesn't relay the information to the person who is making the food. So you'll find that there's loss of communication somewhere. So I feel like we as nutritionists, we address this context, making food and interventions and meal plan practical and sustainable for the people living with diabetes. And I feel like this is the heart of behavior change, not restrictions, not telling them don't. For me, I run away from that. Hata mi ukinikujaza no, I will encourage you and show you what to eat, and not really focus on remove this. When you do that, you're fostering a negative relationship with food. So going to understanding our role as people in the bigger healthcare team when it comes to diabetic management. We are not just food police, that is what we are known for. We are partners in behavior change. We do nutrition assessments, we look at the labs, we look at the medication, we look at the psychosocial factors, access to food, that is food security, my instructions. Sometimes patient anakuja anakwambia unajua mi niliambiwa but I don't understand, so you try and simplify it for them. Promote food literacy, helping them to understand why they eat what they are told to eat, why and how. Sometimes even you can show them how to make nutritionally adequate food. We do counseling, tools like motivational interview, smart goal setting. For me, I really rely so much on smart goal setting, because I want the goals to come from the client to help them change their habits gradually. And when someone is told they have diabetes, you have to really take them one step at a time. You have to explain to them what diabetes is and why they're being told to do what they do, so that by the end of that journey wameelewa. Kwa sababu if they don't understand, they will not translate it. And I feel like we build trust over time, and turning theory into habits that will be sustainable and long lasting. So our role complements you guys as doctors. We bring day to day implementation support that medication alone cannot achieve. I want to look at a case study. So this is a fictional case study. I have not taken anyone. They might look similar, but this Mr. A is very fictional. He's a 52-year-old diagnosed with type 2 diabetes on metformin. His fasting blood glucose averaged to 8.1 millimoles per liter, and then his HbA1c is around 8%, which is quite high. You know the normal. I already shared it. Now go look at the video I already shared. When we reviewed his habits, we found out that he skipped breakfast due to work and compensated by overeating late into the night. So the doctor who was seeing Mr. A focused on the dose adjustments, and going and still coming back, the sugars were uncontrolled, because there was the aspect of skipping nutrition counseling, which from our collection, you'll see that he's skipping meals. So the main issue here was meal timing and the composition of what he eats, because he skips breakfast and then he eats less into the night, high refined carbs, and he is type 2 diabetic. So after Mr. A was sent to a nutritionist, counseling was done, and a structured meal plan that incorporated meal timing, fiber inclusion, and portion guidance. There was an drop in HB1C by 1.3% in 3 months, which is quite good. And the key lesson from this fictional case study is medication plus consistent nutrition planning equals improvement. Because one aspect, diabetes has around five, and I always promote each and every of the five, because if you miss one, you're going to really have a hard time. This was just to show if nutrition was left out, you will not even find it's not the medication. Mr. A is taking the medication, but look at what surrounds the medication in terms of eating and all that. So, bridging the gap, what should doctors know? Now we come to the main theme of this session. Nutrition care amplifies medical outcome. We wish doctors knew nutrition care simplifies their work. When diet and medication are aligned, patients achieve glucose control, there are fewer hypoglycemic events, and greater adherence. So small adjustment, meal timing portion can improve the glycemic control. Um, Unified message from the doctors to the nutritionist to anyone handling the patient will prevent confusion and conflicting advice, which most of the time, if a patient experiences this is being told here, this is being told here, they lose trust. Nutrition counseling enhances medical adherence by reducing the side effects, and doctors and nutritionists working hand in hand shorten recovery time and improves the satisfaction of the person living with diabetes. So let's work together. Yes. So when collaboration works, teamwork really save time. And I feel like and also the long-term cost. Studies show that multidisciplinary diabetes care reduces complication and hospitalization rates. Early nutrition referral within the first month, let me say within the first week of diagnosis, improves glycemic control because the patient will know what to eat. Patient receiving combined medical and nutrition education maintain a lifestyle change longer compared to someone who just either received nutrition counseling alone or maintain or receive medical care alone without the nutritionist being there. Shared session reinforce consistent messaging which builds accountability. If a doctor says pitia kwa mtaalamu wa lishe atakuelezea vile ya kukula, patient really trust doctors, so they will come, and when you educate them and show them that you're also competent with what you do, you'll build accountability and you'll improve the trust of the patient. And a good collaboration doesn't compete. Mimi sitakuja nianze kuprescribe dawa. I will never do that, and I will never expect you as a doctor or anyone in the healthcare team to come and start prescribing doctors. So I feel like it completes the care process. Each one of us have their own role. Like I call them a branch of a tree. Each branch has its own function in the tree, which is the patient. Yes. So the missing ingredient is empathy. Diabetes is a diagnosis, not an identity. And this comes from, let's say, the data will put out will show, because from the attitude you will find some people did not like being called diabetic or kuambiwa kuna shida ya sukari. So most of them feel judged if they come with poor control. So that is why really empathy comes in. Open conversation, because if the patient comes to you and you're not judgmental, they will be able to open to you na wakuambie yake, mimi nimekuwa nikicrave kaskari nikakula, that's why sugar ziko hivi. Sometimes during the day I feel fatigued. You also have to check vile anakula, because any slight uncontrolled sugars, maybe hypo, might cause fatigue, stress from work or stress from managing all that. Language, avoid labeling them as non-complacent or nonchalant when they're here. You utaniambia mimi, but when it comes to them, you really have to sweeten the word so that they see you as a person they can rely on. Nutrition session create a safe and judgmental environment. That's why sessions usually go for 45 minutes, sometimes 1 hour, because you're getting to know this person, you're building rapport, and when empathy leads, adherence follow. And I feel like that is the most powerful clinical tool I have seen. Barriers to collaboration, like I said, there's weak referral pathways. Many clinics, especially around Kenya, they lack a structured nutrition follow-up system. You might see a patient who might need nutrition, and since nutritionists we are limited, utapata hospitali moja iko na nutritionist moja mwenye anakuja specific day, so you might find akiambiwa arudi, they will not come back. Knowing what you're supposed to do so that there's no overlap. Yeah. Limited insurance. I feel like some insurance companies don't cover nutrition services, and people don't want to pay out of the pocket for nutritionists. I don't know why. Communication gaps. Lab results are rarely shared across discipline. But these days, if you have that file, this in the diabetic clinic, there's a standard structured data collection form that everyone has to fill. So when you open the file and you see everything is there, so I really appreciate that. But in some clinics, you might find it's not shared across. So you have to go and look and look and look. Yeah, continuity in education. This is rarely includes interprofessional session, which limits mutual. I don't know how many hospitals really, apart from KNH, call on nutritionists to give CMEs and webinars for people to know what we do. What we could change, imagine if nutrition was routine as prescribing metformin. I know that is far-reached. Integrated nutrition in the medical training and CMEs, like I said, please be calling nutritionists to the CMEs to give you what to look out for in case you come across a patient. In the medical school, at least wafunzwe kidogo, but you as a nutritionist in the clinical setting, you can also be champion to be called upon so that you can give CME. Automatic referral protocols. I think in the nutritionist corner, we're really following up on the referral protocol so that we really do well. Joint clinic days, because in some clinics, like I said, nutritionist anakuja mara moja or mara mbili. So if you can really work around the timetable so that if it's diabetic day, a nutritionist is there so that it's easier when they're sent, we can work together. Shared electronic record if umefika in the digital era of files. Promote national diabetes education initiatives with nutrition front and center. So moving forward, these are just practical tips I'd like to share. Small steps toward integrating care, co-creating shared treatment goals. Um, for me, when I worked in the hospital, I used to really liaise with the doctors. I used to say I have this patient, na hata wananitumia. So when I tell them this is what I had in mind, of course, umeandika kwa file and we follow through. This is our target, this is our weight, this is the meal consistency. When they see something I miss, they come and tell me. Communication builds respect. Making sure they share everything they know about the patient when they send the patient to you. Bado utafanya assessment yako, but at least you have a baseline. Using simple shared language for patients, advocating for team-based case reviews. And this is, I came across this when I did one session at the corner where I talked about communication. You can be having weekly team-based case reviews where you call in each team members to talk about the patients you have seen, celebrate doing success. That is really good. I feel like these tips will strengthen collaboration between the two cadres. From control to connection, move from don't eat this to here is how to make it healthier, because don't really reinforces the negative relationship with food. Compliance to collaboration, blame to understanding, individual management to shared support. Because I feel like when we reframe this conversation, that's why I've bolded and put them in quotes. The goal is to empower, not perfect. Every step counts. Because we might have our high days and our low days with the patient. So yeah. So key takeaways from this session: better together, doctors plus nutritionists equals stronger outcomes. I will do another session with other healthcare cadres. I've not neglected. I will keep on repeating that. This is just one of the episode. I will make others about nursing, about pharmacy, and all those other healthcare professionals. So nutrition is not secondary; it's central. Medical treatment without dietary support lead to partial results. Collaboration enhances adherence. Empathy plus education equals behavior change, and that I can tell from experience. Together, we can transform diabetes management from treatment to empowerment. I didn't want this session to be long, but I got carried away because I'm very passionate. So let's keep this dialogue alive. This conversation is about connection and not correction. If you've seen, I've not corrected, I've just highlighted our strong points as nutritionists. I invite all the healthcare providers that kama nimewacha nje to see nutritionists as allies and not as add-ons. When we come in the team, make sure we are well received so that we can work together. And the diabetic desk is a space for continued learning and collaboration. So if you want to collaborate with me, feel free, leave your comments, share stories, any encounter you've had, any successful collaboration, feature co-presentation. If you want to, know together we can nourish, help, and not just manage a disease. So thank you so much. I've actually enjoyed this session. I hope you do too. If I've missed said anything, please let's discuss. I want this to be a vibrant video so that we can learn from each other. And until next session, I've been yours. Bye.